Hey, George, good morning. It's another Tuesday morning. How are you today?
I'm doing pretty well. Today we have another fascinating guest, Dr. Kimber Simmons. And her topic today is going to be pediatric diabetes. Are we closer to a cure?
Dr. Simmons, welcome to the podcast. Thank you for making time for us all the way out there from Aurora, Denver.
Of course, thanks
Oh,
for having me.
how are you today?
I'm well, thanks.
We always start the shows asking people, why did you become a pediatrician? In particular, why did you choose the subspecialty of pediatric endocrine?
That's a great question, and it's become easy to answer over time. When I decided to do medicine, I didn't quite know why. I just liked it. But in retrospect, and specifically why I'm in pediatric endocrinology, is from my own personal experience of being diagnosed with type 1 diabetes when I was 8 years old. And I think that from the time I was little, I had hoped that there would be people who would work hard within the field to make lives for people with type 1 diabetes better. And I am really happy to be part of that now.
Thank you. What was it like from the perspective of an 8-year-old, if you can remember? I would imagine it's even hard to digest what that diagnosis means.
It is hard to think about what that means long term. You don't. You just think about at that moment what's happening to you. And really, what I remember was just being scared of needles and feeling like I was being forced to have IVs placed and people standing around me and doing things to me that were new and uncomfortable. And I didn't really understand why. But I had no idea at the age of 8 what that would mean for the rest of my life as far as the daily burden of chronic management.
I think for me, because the kids are so resilient, but for me, the hardest thing, it makes me cry, is how do I help these parents? Because we all, as parents, want our children to have what we consider a normal, healthy life. And anything that's not quote unquote normal, it is such a shock to the parents and all this new things that they have to learn. And eventually, within, I think, about 18 months, they know more about the management of diabetes than I could ever know. But I think the parents are so difficult, such a difficult journey for the parents.
It is a really difficult journey, and I think that's one of the things that's special about what we do is you have to take care of the whole family because the family is impacted in different ways, but just as much as the child, and so it's a really special opportunity to be a part of that whole family's life and helping them deal with type 1 diabetes.
Yeah. In the past, we used to say insulin dependent diabetes and non insulin dependent diabetes. And I think that nomenclature has all changed. And now we talk more about insulin resistance versus type 1 juvenile diabetes. What is insulin resistance? And how does that lead to what we commonly refer to as type 2 diabetes that keeps crawling into our exam rooms today with the adolescents and the preteens?
Sure. So I think insulin resistance is when people make insulin, but their bodies don't use it in the same way as someone who is not resistant. So, how I usually describe it to families is I talk about how insulin is a bridge that builds and lets sugar go from your bloodstream into all of your cells for energy. So, your brain and your heart and your muscles. And in people who have insulin resistance, that bridge becomes really narrow. And so the sugar can't get into the body very easily. And in order to make that bridge bigger, you have to find ways to decrease the insulin resistance and open it up wider. And you can do things like exercise more, eat a better diet, lose weight, and potentially use pills. So that is commonly type 2 diabetes, what we talk about. And I think one of the important things to think about is it's not that everybody gets type 2 diabetes because they don't have a healthy diet or they don't exercise, but there's a strong genetic predisposition to having insulin resistance. And so you have people that are genetically predestined to have insulin resistance, and all those lifestyle factors just become really important to controlling glucoses and making sure that the insulin can get into the body for energy.
That's a wonderful explanation. I listened to, I think, three-quarters of an episode of Peter Thiel, and he had a researcher on insulin resistance. They started talking about something called mTOR, and I had no idea what it is, but it's some enzyme near the mitochondria that is very much related to your muscles, insulin resistance or not. And they really turned my world upside down in the sense that you can be a normal BMI 20-year-old college student with a normal hemoglobin AC1, and if you become non-active, they can start measuring your insulin resistance. While the next person, same parameters, not any more active than you, are not insulin resistant. And the second takeaway from that that was fascinating to me is that most of the insulin resistance happen in two organs of your body. I think, I don't know if I'm right, but I just was what I took away from it. Your liver,
Mhm.
and the other one, which is much more important, is your skeletal muscle.
Mhm.
If you can't get the insulin into your skeletal muscle, you are in big trouble. And that's where not exercising is really hurtful because you need to build that muscle, which is tons larger than your liver. But it was a fascinating conversation. I didn't know any of these concepts.
Hmm.
And I still don't understand what mTOR is, but
Yeah.
someday.
No, there are a lot of experts who deal with insulin resistance at the muscle and liver level and fat all the time. And I also am not educated in that, but I do know that we clinically, even our kids with type 1 diabetes, when they get to a certain age, if they have a strong family history of insulin resistance or type 2 diabetes, they also will have insulin resistance. So it's something that we really see
Wow.
in anybody with diabetes that we have to think about.
Oh, wow. I didn't know that. So you have to increase their doses of insulin or get them to exercise more? What do you do with those kids?
Yeah, their total daily doses of insulin are typically much higher. Their carbohydrate ratios and their correction factors are much more aggressive. And sometimes we consider using adjunctive therapies, although the data in pediatrics isn't very clear as to the benefit of that.
Yeah. Yeah. Now, what are islet cell antibodies and what role do they play? I'm an oncologist. That's what I remember from medical school. So, what are they and how do they play a role in this insulin dependent disease?
Sure. So, people who develop type 1 diabetes have that process start years before they know that they have diabetes and have the symptoms of drinking too much and urinating too much and potentially losing weight and being hungry. But what happens years prior often is that the immune system makes a mistake and the T cells start fighting off pieces of the beta cell that make insulin when they shouldn't. And when that starts happening, so that autoimmune process starts happening, then the B cells make auto antibodies in response to that, showing that process is happening. There are four major biochemical antibodies, and those are immune markers against proteins of the beta cells that make insulin. So there's glutamic decarboxylase or GAD, there's insulinoma antigen 2 or IA2, zinc transporter 8, or ZNT8, and then there's also an antibody to insulin. And so those are really important biomarkers because that's the one thing that we can measure right now to know that someone is on the path to developing type 1 diabetes.
If I'm correct, now there's three stages. I guess I'm going to call it a juvenile onset diabetes, right? You can have the positive serology for the autoantibodies, and your glucose, your hemoglobin AC1, and your glucose tolerance test is negative.
That's correct.
Then you can have the second type or subtype where your daily glucose is normal and your hemoglobin AC1 is normal, your antibodies are positive, but now you have an abnormal glucose tolerance test.
Pretty close. I think it's important to realize that these stages initially, when they were designed for the purposes of clinical trials, and so it was because to answer a question in a clinical trial, you don't want it to take 20 years. And so you wanted to identify people who were at highest risk for progression to clinical diabetes to see if the medication that's being studied has an impact. And so those clinical trials were really meant at trying to differentiate who's at the least risk for progression, who's at the higher risk for progression. And then over time, it's become part of the American Association Diabetes Standards of Care, where diabetes is now staged. And so that stage two that you were just talking about, that second stage per the ADA, isn't just an abnormal 2-hour oral glucose tolerance test, but it also could be a slightly elevated hemoglobin A1C between 5.7 and 6.4, or a fasting glucose between 100 and 126. So it's really showing signs that blood sugars are beginning to have abnormal values, but they're not hyperglycemic yet and causing symptoms.
And does measuring fasting insulin help you in that decision tree?
It
Are they
it
producing more insulin because or the islet cells are not good, but is the body trying to produce more insulin or and still keeping up or not at that stage?
Over the stages, what's happening is that you're losing beta cell volume and also some beta cell function over time. So if you were to measure beta cell, a measure of beta cell function by doing like a stimulated C peptide, which is a measure of endogenous insulin production, you would see that over time that's decreasing. And so
Okay.
as you move through the stages, your C peptide or your endogenous insulin production becomes lower.
Okay. And then type 3 within the juvenile onset is what we clinically recognize.
Yes, so
That would be
stage
the
3.
glucose, what you said, polydipsia, polyuria, weight loss, ketoacidosis. That's stage 3.
That's right. Yeah. So it's
Yeah.
still all type 1 diabetes, but now there's the stage 1 and 2, which are before clinical onset, and then stage 3, which is what we've all thought about type 1 diabetes being for a very long time.
And in today's world, and please feel free to interject and correct me. I'm just what I see in the clinic and what I've seen for the last 30 years. Most children are on an insulin pump, and that's how we try to manage their. I'll say it's a hormonal imbalance. They don't have enough insulin, so we try to add additional exogenous insulin to manage their glucose, and that's pretty much the standard of care.
I think that we would all like for patients to utilize technology because we know that it improves glycemic control. And we also know that some of the newer technology can decrease the burden, which is huge. But I think that even though that might be the standard of care, there's still a lot of work to be done with making sure that everyone has access to that technology and that it's equitable. We have high adoption rates of technology in our clinic, but we do have differences based on race and ethnicity, for example, that we need to figure out how to do a better job at making sure everyone can be on those amazing pieces of technology.
Yeah, and unfortunately, education plays a big role. I have one patient that I diagnosed way back, and the mother's a type A. She's just on top of everything. She's just his personality, and she was one of the early adopters. This is over 10 years that we diagnosed them, and she would get text messages on her iPhone when her son's glucose was over 250 in the school, and she would text the teacher. You have to lay off a little bit. The glucose is gonna go up occasionally. You cannot be measuring it every minute of your day. You cannot be obsessed. But the more educated you are, the more involved you are and more resources you have. And sometimes you become hyper vigilant and you don't let the kids have they're gonna be kids. Once in a while, they're gonna eat ice cream and their glucose is gonna go up. If
Hmm.
hemoglobin AC1 is steady and they're otherwise are doing well and compliant, you gotta look the other way. I mean, you can't expect perfection out of any human being.
Dr. Simmons, why do you think some kids will use a pump and some kids won't? I mean,
Yeah.
here in the United States, there's mail, there's the insurances are all over the place. So I don't think their access to a pump is the issue. Because you can be in the middle of the United States somewhere and United Healthcare is your carrier. As long as they approve it, they'll ship it to your house. Is it really equity? Insurance is insurance.
It is to some degree, although in Colorado here, probably our government insurance covers that technology better than any other commercial insurance.
Uh-huh.
But as you're mentioning, we have trouble having people adopt that. And I think those come down to some barriers related to all the training that it takes to be on a pump and feel comfortable. And so there might be some like language barriers or trouble attending trainings, or we have people do virtual trainings for home and they'll try to do them on their phone and maybe they're not quite as effective. I think there's still a lot to be learned actually about what all of those barriers are and how we can work to overcome them. But you're right. It's not that for patients that have government insurance, it's covered very well. It's just
I
having the tools to be able to
Yeah.
lead that. Yeah.
that
Yeah,
there's
'cause
so
I'd
many
seen one. I've seen one endocrine clinic where everybody was on sliding scales and such, and the chief physician was older than Dr. Bravo. So I think if he didn't quite understand it, how does he recommend something that he doesn't quite understand.
Also, these things are all, what is it that they call it in the tech world? The power of everything or the connected of everything, something like that. Or your refrigerator, your oven are connected to the internet. I don't know what for. And a lot of these things need the internet.
Mhm.
That's how they can, when the glucose is off on me and it pings my mother on her cell phone, I
Mhm.
need to have an internet connection. And although it's not understandable for us, there are many communities, urban communities, where internet is not available to
Mm.
poor people. And there are many rural communities, they call it the last mile, where the cable will come to the main road. But once you go off the next mile to where the houses are, no one wants to invest to put the cable down because it's too expensive and they're never going to recover the cost of the infrastructure. And if you can't connect to the internet, you can't update the devices, you can't communicate with your doctor. It becomes really difficult. And that's what I think sometimes we miss because we all live in our own bubble. I can't walk 2 steps without my iPhone pinging me that I left my cell phone behind me at the house, but everybody does not have that level of connectivity. That is a barrier that has been well shown for some people. Age is also a barrier, and I think education is another barrier. Some people don't take diabetes seriously, no matter what you tell them. They just don't think it's that serious. Now, what I've read is that we should be doing population screening and antibodies. How does that? What is the thought process behind that?
Sure. So I think so for several years, since 2014, it's been recommended that family members of people with type 1 diabetes are screened for type 1 diabetes by measuring those autoantibodies that we talked about. And recently, in the last statement from the ADA, they said that anyone should be considered for islet autoantibody screening in the setting of a clinical research study. And that statement was made before there was anything available that you could potentially do medically before somebody is diagnosed. Let me back up just a little bit. 9 out of 10 people almost that develop type 1 diabetes do not have a family history. We know that the people that have a family history are the highest risk. Their risk is 15 to 20 times higher than if they didn't have a family member. But we also know that if we only focus on family members, we're going to miss the majority of kids who end up developing type 1 diabetes. And so that's where the push comes for general population screening is to identify all of the kids that we end up seeing in clinic who have type 1 diabetes before their symptoms develop. And the reason for doing that has been because the rate of diabetic ketoacidosis at new onset is extremely high in the United States. In Colorado, it's over 50% of our kids who are newly diagnosed end up in DKA when they come in.
Well,
But we know that if we identify someone early and follow them over time, that risk of DKA is less than 5%. That's really important because not having DKA at diagnosis, there's data showing that sets you up even metabolically for success later in life. And if you're starting off with a good metabolic footprint, I think that's really important. And then the other reason that I think screening in general is becoming more important and talked about a lot more is because in November of last year, there was a medication approved that can be given to people ages 8 and older that can delay the onset of type 1 diabetes by about 3 years on average. So we now have the first intervention that we can use to potentially change the natural history of the disease.
And so the recommendations have been to screen at 2, 6, and 9. I'm just curious from an implementation point of view, as a general pediatrician, you would make it a lot easier on me if I did it at 1, 5, and 10,
And
just
that's fine.
because
Yeah.
that's fine. Okay, that just works better into my workflow because everybody else is there for at 1 and they get their lead test and they get their hemoglobin. I could screen them then. And at 5, before they go to school, I could screen them then. And the 10-year physical is an important physical. I could get their lipids and I could get these antibodies and see where they're at. And so
Yeah.
that would be fine. It was just a number for the studies.
Yeah, I think, well, when you look at the data, there are several studies that have taken high risk individuals at birth because they either have a family history of type 1 diabetes or they have a certain HLA gene, which is just a gene that is involved in how the immune system presents. So both of those high risk factors, babies that had those were followed over years. And so, from those various studies that have been in the United States and Europe, all that data was collated and said, at what ages, if we screened, would we have the highest chance of catching everyone who develops diabetes? And those ages are 2 and 6. But I think practically, like you're saying, it makes a lot more sense to have buckets like 1 to 2, 4 to 6, 9 to 11. Really, when I think of it, the 1 to 2 year old time frame, you would probably catch more if you did it at 2, but that time frame is to really catch kids who are going to develop diabetes as toddlers or preschoolers before school age. And then when you're doing that school age screening, that will catch most kids who develop diabetes before the onset of puberty. And then when you're doing that preteen screening, so ages 10, for example, then that's when you're going to catch people who develop diabetes through the age of 18. And actually, people that develop diabetes as adults that don't quite develop diabetes by the age of 18. So those are the time points that won't catch everyone, but will catch a lot of the people who will develop type 1 diabetes.
You know what? If
Okay.
you really think about 2, 6, and 9, logistically, it's not a bad idea because people usually go to the physician's office, pediatrician's office to get vaccines. At those particular visits, 2, 6, and 9, which are visits that historically are missed, they don't go because they know they don't have to get any shots. So why should I go to the doctor? Now, if there's something to do, they may actually go to the doctor.
That'd be great if that
Yeah. So
helped people
that's a
get
good thing because you're not
vaccinated.
giving any shots. And then you also have the idea of I gave a shot and then your diabetes screen was positive. Did the shot cause you diabetes to trigger? I don't know.
But what we have seen with school mandates is that because and in Virginia for daycare mandates too. People come in to get their physical because they can't put the kid in daycare.
And I need something.
People come in before they go to kinder because they can't get into school. But the 6-year-old already had his kindergarten form filled out. They don't have to come in.
Yeah.
And then once you get to those 10-year-olds and 12-year-olds and 14-year-olds, man, they're healthy. They don't need to come in and they feel like they're invincible. They don't want to come in for any reason unless they want to cheer or they want to play basketball and they're mandated to get a sports physical. Other than that, it's you got to go with an ice cream truck through the neighborhoods and pull them out of the houses to get them to do their physicals. So that's why I'm saying that maybe at 1 and 5 and 10, it would be they're already there. It's like what I tell parents, don't wait till the kid's too old to give them the vaccines. If I could, I would give them all the vaccines at 2 months. They can't run, they can't fight me, and I would just be done with it and they won't remember it. But that's not yeah.
Yeah, I
Anyhow,
think you'll lose a little sensitivity, but I think the point is really to just be screening a few times during childhood in the way that I described, and that will be helpful.
okay. And the screening is pretty simple, right? It's not a full blood draw. It's a finger stick, and then they do it off of a card, and that's it.
It can be done. So the antibodies are in serum, and so you can get serum from a capillary stick with a finger poke or from a venous blood draw. Either way, so it really just depends on the family's preference. I actually think sometimes it's better just to get a venous blood draw than it is to squeeze a finger for a really long time. But
Okay.
depending on the clinic and what's available, either way is fine. With the finger poke, there are some people who do dried blood spots. There are also others that do like capillary tubes, so small tubes where the blood would go in. And then the venous blood draw obviously is in a vacutainer.
Okay. And I think most clinics do mostly finger pricks. They don't have the time to be doing venous sticks.
Yeah. So
And then
the capillary blood tubes, the results are the same as if you did a venipuncture.
okay.
Yeah.
And then this is where I get all confused. And I get all confused with Beyfortus and I get all confused with this new drug. So we now have the ability, which I think is a miracle, to create monoclonal antibodies that target a certain protein of a virus or a cell in the body, and it prevents disease. So these monoclonal antibodies in diabetes, what are they targeting? Are they covering the B cell antigen that's producing the autoimmune response? Or are they covering the T cell? Where are they being affected?
So these monoclonal antibodies, teplizumab or Tzield, are binding to T cells, to the CD3 part of the T cell receptor on T cells. And when they bind, the T cell receptor internalizes. And from animal studies, it looks like those T cells go out of the circulation and then they start to come back into the circulation rather quickly. But when they come back, they're exhausted. They have what we call like an exhausted phenotype. So they aren't activated against the proteins that they were previously fighting. They can still respond to viruses, for example, but they can't respond. They don't respond as much to beta cell proteins.
Okay. So it's fluctuating at the T cell level.
That's right.
Okay. Very interesting. I like that term exhausted. Maybe somebody threw some monoclonal antibodies at me because I feel exhausted some days. I know this is an unfair question, but I was just thinking as I was reading last night and preparing for your conversation with us, Beyfortus, they were able to take a monoclonal antibody, and I haven't been able to figure out where this Beyfortus goes. Does it go to the T cell? Does it go to the RSV virus? Where does it have its effect? But then they naturalized it, and through a process, they make it hang out in your bloodstream for 150 days. And I was thinking, is that the future of prevention of diabetes? If we can make these autoimmune antibodies hang out for 6 months, we get 2 shots a year when we have these markers, and that would keep delaying the onset.
That's really interesting. I haven't really thought about it that way. If you were able to keep monoclonal antibody like this one around for longer, what that would do. I think I don't really know the response to that because we don't even know other autoimmune diseases require often multiple infusions. And it's not that you just
Yeah.
get one and that's it, but we haven't really figured out in type 1 diabetes if that's what we also need are repeated infusions or if you need to actually come at the immune system from another direction and use another medication in addition to the monoclonal antibody. So those are clinical trials that are being put together and ongoing. And I think there's a lot to figure out about what the best way to treat type 1 diabetes or hopefully prevent it in the future. But I do think even though this is just the beginning, it is like you were mentioning earlier, it's amazing that the door has been opened and that there's something that is actually available now that can alter the natural history of an autoimmune disease. And as far as I'm aware, it's the first therapy in any autoimmune disease, not just type 1 diabetes, that you can actually change the course of disease.
Yeah, it's fascinating. What if, because that's what happened with the first monoclonal antibody for RSV, right? You had to give a shot every month during the RSV season.
Mm.
And then they figured out, they put it through some bath or something, and now it stays in the kid's bloodstream for 6 months, and they can just give one shot, and that's it. So it's incredible if that was a path that we could, it would be like AIDS. We don't cure your disease, but we keep you at a level where you don't need to ever shoot yourself with insulin. That would be huge. Now, what is this medication? It's a monoclonal antibody for T cells, and it's commercially available now, right?
That's right.
And as I understand it, is an hour-long infusion for 14 days in a row.
It's a half hour long infusion. The rate can be slowed down if the patient is having any side effects during the infusion. But in all the patients that we've infused, we've been able to do it over a half hour.
And generally, children's hospitals with a big endocrine department and an infusion center are doing these.
Yeah. So I think that it's something that is still being really nationally put together because having an infusion of something that is 14 days in a row isn't something that happens in even oncology. And so weekend coverage and figuring that out, even within large children's hospitals, requires some work. But
Yeah.
our feelings, people that have worked with this drug and talked with people who administer immunotherapies in other areas is that this medication should really be administered somewhere where there's expertise in pediatric trained people, for example. Not that
Okay.
there's a high risk of side effects, but you want to have everybody get this in the safest environment possible. So an infusion center or an office based, infusion center or a hospital's infusion center are probably the safest places.
But it
Okay.
sounds like it's gonna be almost like a little hospital admission to do this.
Yeah, you
Now, how
so
do you
we
even
are.
keep those
Yeah.
people in there?
Yeah, I'm just advocating for I don't want my patients to be getting it at home where they may have
Yes.
something happen and they, can't get to a hospital. But the chances of something happening where they would actually need advanced life support is extremely low. The thing that we most worry about with the medication is cytokine release syndrome, overactivating the immune system and causing a lot of it kind of inflammation. And we administer it for us in our office based infusion center. And we know that if a patient was to have symptoms, that we would need to further evaluate them and we would send them to the hospital if we were concerned. So that you just have to have a plan for how they could get the care they need if they need it. But our nurses who are administering the drug, for example, are all trained in that so that they would know the signs and symptoms of when care needs to be escalated.
You could, in well-run pediatric emergency, pediatric urgent care, led by pediatricians with infusion nurses that are trained and are PAL certified, would also be a very viable in your neighborhood option. Because we got to remember that the children hospitals are understaffed, overburdened, and underpaid. And so we cannot continue to, excuse my language, dump everything on the endocrinologist or the children's hospital. We have to do our share so that they can be available for the more complicated patients that we need the most help with. So maybe a really well run urgent care could adopt something like this so that it's available everywhere, not just in big metro areas. Because we forget a lot of people don't live near a metro area or near a children's hospital. Now, what is the skinny on this study? I read it and I got all confused, and I don't do a data analysis very well, but it seemed like they took the highest risk kids, siblings of people that were already diagnosed with diabetes, and they gave them this infusion for 14 days, and they were, in a large part of the kids, able to delay onset of type 1 diabetes by something like 2 years or more. But then there was what I think I understood, which I like more because I'm a Pollyanna kind of person, is that there is a subset that didn't seem to develop diabetes after this infusion. So, what are the real numbers from somebody that actually does this research?
So when you were looking at this group and you had all the general details right about this study. So 44 people received the active drug. And when you're looking, you don't know if someone did not get the drug when they would develop diabetes. So really how you have to look at it is you have to look at the difference in time to developing clinical diabetes between the group that received the drug and the group that received the placebo. And so in the follow-up study done after the initial study, it showed that the difference in time to diagnosis was 32 and a half months, so almost close to 3 years. And I think when you're looking at that's on average, but I think what's important to note is that not everyone responds to this drug. Just like with every immunotherapy or every treatment, not everyone's going to have an excellent response. We don't know if not having an excellent response means that you have a little bit of an improved response, meaning a little bit more delay or nothing. That's hard to tease out because we don't know again when they would have developed diabetes. But we do know that the people who do respond well go longer than that 32 and a half months from developing diabetes. So that almost 3 years is an average of people who just develop diabetes at a normal rate and people who have a really good response and a good delay.
And that's what gave me the most hope
Mhm.
that we're getting close to a long term management that doesn't involve insulin and pumps and daily shots and ketoacidosis. And as Dr. Offit often says, the tyranny of small numbers. So when you're dealing with very small numbers, you're limited to the power of prediction and anticipating unknown. You only see that when you're started using it the population in general. Here's where I have some concerns, and it's more about how we finance healthcare in America.
Mm.
As I understand it, this infusion costs almost $180,000. That's what the medicine costs.
Mm.
That doesn't include the infusion center, the doctors, the endocrinologists. That's a hefty price tag if you're looking at it from a societal point of view. I'm not, of course, if it was my son, my grandson, my niece, I'd be like, who cares? Spend the $200,000, give her 3 years without having to give herself insulin shots. But from a societal point of view, that is a huge amount of money to spend on one intervention. And I'll make the same criticism of Beyfortus. It's a miracle drug. Can you imagine if we could stop the little 3-month-old from getting RSV and ending up in the ICU? It's worth $500. But in aggregate, if we give this product to every newborn at risk, it's a $2 billion spend. And again, I'll make this point again. Our children's hospitals are understaffed, overburdened, and underpaid. And I can't reconcile, and I like Sanofi. I'm not hitting on Sanofi in particular. I can't reconcile taking $2 billion and moving it from supporting children's hospitals, pulmonary specialists, ICU specialists, hospitalists, ERs, taking that 2 billion and giving it to pharma. And then when I do need that inpatient bed, it's not going to be there because they don't have enough money to sustain it, which is what we're seeing at the community level. And for the life of me, I haven't been able to come up with a solution of how do we bring about the finance of these medicines, which I think at the end of the day is going to be the federal government. Nobody has big enough pockets to take these hits, not even United Healthcare. And you can't do it at the Medicaid level because some states have more money than others, and some can't they just can't afford it. And so I think these are going to have to be funded by the federal government. And we're going to have to set a tariff or a percentage that gets fed back into primary care and into the children's hospital to maintain infrastructure. Because I need endocrinologists. Maybe I only need them once a year, but I need them. And I need a pediatric ICU bed when somebody is in a car accident. And I can't vaccinate against car accidents. And someone's going to unfortunately get cancer. I need a good neurosurgeon for that baby. And I think we haven't had that conversation. And it worries me because now is the time to have them because I think we're going to have more miracle drugs. And we need to keep the infrastructure. We need the endocrinologist. We need the children's hospital. We need to continue the research. And we can't just shift from one bucket to the other and forget about the needs of the community. But that's just me thinking out loud about how are we going to finance this, which I
I
think
always ask the drug reps, why are these medications so darn expensive? Why should it have a ticket of $185,000? That's all
Mhm.
your research and development, how many things they bring out that don't go to market and they lose on. But still, $185,000 for one patient seems like a lot.
It does seem like a lot. I think we're in the realm right now of rare population because there aren't a lot of kids that have been screened. So
Mhm.
I hope that will change over time and that if there's approval outside of the United States, that will also drive a difference in the cost here. But yeah, I agree with you. Our healthcare system is really broken. And in working with this and really developing our infusion program and our immunotherapy program here, I've learned even more about how broken it really is. And it makes me very sad, and there are definitely things that need to be changed so that our patients can be taken care of in the way that we know they need to be taken care of.
we've done this in the past. So this will get resolved, right? If you go back to the 1980s, I remember this because my younger sister's quite younger than me. She couldn't get vaccinated. And it was all because the pharmaceutical company said, enough. We're getting sued right and left with DPT, and we're not going to take that burden anymore. And they stopped providing vaccines. And so the Congress moved to create the Vaccine Compensation Act. And now they have a tariff per toxoid. So 75 cents per toxoid. And you can't sue outside this vaccine compensation system. So you can't sue the pediatrician, you can't sue the pharmaceutical house. And they started manufacturing, created better vaccines, and life went on. And then we got to the point where if you were not insured or if you're commercially insured, some people didn't have preventive medicine. Child vaccines weren't paid for. Vaccines weren't paid for, only sick visits. And so we came up with a vaccine for children program. And so now your pediatrician could give you the vaccines If you were not insured, or in the old days, your health plan did not cover vaccines, just like everybody else. And we did it, and we found a way. So I think we just haven't had the conversation about these miracle drugs. How do we finance it so it's equitable? And how do we set it? I call it, again, I'm a great fan of Dr. Offit, and I call it the farmer mentality. When you're racing corn, you take the best corn, you set it aside for seed for the next season. And when we think about these miraculous interventions, we must take some of that best corn and plow it back into the infrastructure that our communities and our children need. But we will get there. It's just we haven't worked it out. And even more optimistic, I know we don't have the answers, but I think this opens the door to so many ways of thinking of how we may be very close to a cure for diabetes. What are your thoughts about where the future research will concentrate?
I think that the research is going to have to adjust currently. I think because there is something clinically available now, instead of trying therapies with the placebo group, we have a standard of care. So more people will be treated in trials, hopefully, eventually, because everyone hopefully will receive something. But we have to adjust when we're doing research and accounting for that, which is something that within the research community takes some adjusting and some time. But so I think other immunotherapies against compared with teplizumab or Tzield is one way that or one place where there will be focus. I think that there's also a lot of research focus on beta cell regeneration and transplant, stem cell transplant. And I always think like maybe in the future for people that already have diabetes, if you can put cells back and you still don't know how to turn off the autoimmune process, but instead of doing immunosuppressants, you can give an immune modulating drug, then that might be a path forward for people who already have diabetes, which I think is very exciting.
That I love the way you think about that, right? Because these immunosuppressive drugs are not very good. But if you could give someone an infusion with the insulin producing cells,
Mm.
and they can migrate to your pancreas and give them a monoclonal antibody to shut down the immune attack of these cells, you might start producing endogenous insulin again.
Yeah, I think it's really interesting to think about all of those things. And I think within the next 5 to 10 years, I think there'll be more than one thing clinically available. And that once things become available, then that pushes for more things to become available. So we're just seeing the ball rolling. I always think akin it to like the first cell phone, which we
Yes.
look back and we're like, that wasn't very good. But at the time, it was great. And I think there'll be hopefully quick evolution in this field over the next few decades.
And so, what are you going to do for a job when diabetes is all gone?
Yeah. I wish in my lifetime, if I could not have to take care of people with type 1 diabetes, that would be a dream come true. I still think there'll be a need for me, unfortunately.
Yeah, there's lots of endocrine disease out there that sometimes it's too complex to manage. What have I not asked you that you think is important for the audience to hear the message of whatever you want to talk about as it relates to diabetes in the future?
Sure. I think one of the things you were saying earlier about how there are people, not everybody has access to a big hospital setting, for example. And I think because this is also new, there's a lot of questions and a lot of good questions about not only what does screening mean, how do I take care of patients after they screen, what about this medication, but also feasibility and implementation and all these things. And we established a program a few years ago called Ask the Experts. And I know that seems like a very generic term, but asktheexperts.org. And we actually, our goal is to work with pediatricians and work with primary healthcare providers that screened their patient and don't know what to do next, or want to screen their patient and don't know how to do that, or have questions about a medication. And what we try to do then is train someone within their practice or someone locally so that they have the knowledge they need to take things on. And then if their practice doesn't allow for extra whatever the things are, if they can't see patients and can't prescribe like a CGM because that's too much in their clinical workflow, then we can support remotely. So our hope is to partner with primary care providers, support them to do as much as they want to do, but also support them in what they feel like they can't feasibly do so that we can take care of this early stage T1D population.
Wow, that's a phenomenal program. And this is funded through grants?
Probably.
It was funded through the Helmsley Charitable Trust, which is a trust that gives a lot of money to type 1 diabetes research
Hmm.
And
and
then
program at it.
are you limited as who you can help because of licensing? If a practice in Virginia wants to ask the experts, can you still help or are you limited to the state of Colorado?
No, we can help nationally. We've talked with everyone and we have all of our ducks in a row as far as what we can and can't do under our medical license. We can't manage someone and tell them what to do, but we can give advice about what we think would be best for them to do.
And this ask the expert is in particular for the screening when they turn positive, or
The
is it
program
when he is that the focus of it?
the program was developed specifically for when people screen positive and have no idea what to do, or their healthcare providers don't know that we work on that. But what we have gotten inquiries about really ranges anything from how do I screen to how do I treat with Tzield, for example. So we are open to really any questions and triaging to the appropriate resources. Our main focus, if we're talking about how the program was developed, is to help make sure there's a good care plan in place for patients who screen positive.
Oh,
We spoke about a lot of things and how to screen. For our general pediatricians, and I'm confused. How do you screen? What do you do? How do you order something? Is it an
Yeah.
in-office test? Is it a mail away test? Is it you send them to LabCorp?
Yeah. So all 4 antibodies are available commercially. So
Mhm.
you can't order them commercially. I think that you could get into the weeds a little bit about there are differences between results depending on where you send the test and what's the gold standard versus not the gold standard. But I really think right now the important part is just to get someone screened. And if it happens to come back positive and it may be a false positive, then we like the Ask the Experts program I was talking about, we can work with you to get a confirmation test for free at the Barbara Davis Center, for example, which is the lab that did all the antibody testing and all these research studies that have been presented. So I think whatever's accessible, wherever you would normally send labs, that's where you should probably do your primary screen. But then if something becomes positive, then we can help support do confirmation testing, or you could just repeat testing at your commercial lab too, because that increases your positive predictive value if you do it twice.
So what is the test called? A diabetes screen, like a sickle screen, or
Yeah.
I don't that'd be
something else?
body.
So it's those 4
Or
antibodies.
for
Those 4
antibodies? Okay.
antibodies. Some labs, like I call it a diabetes antibody panel, and
Okay.
they have put them together. But when you're ordering it, it would be asking for each antibody to make sure that you're
Separately.
getting all of them.
Okay.
And like we said before, you can get it from a capillary and they put
Yeah.
it on the card and you send that to Quest LabCorp and they'll run it from there.
The card is not done by commercial labs. So for
Okay.
commercial labs, it would be, or so it needs to be not on a filter paper card. The company that does a filter paper card right now is only doing clinic-based screening. So it would be, they're called Enable, and you would have clinic kits in kits in your office actually, that then you would
Okay.
send to them. And then the Ask program in Colorado, where we do general population screening, also for pediatricians that are interested, we can have kits in their offices as well, and their finger poke kits that use capillary tubes. So if you don't want to do it commercially, there are also those other options outside of commercial. Enable is a self pay situation. I think their price is $85 for all 4 antibodies, but I don't know for sure. And then Ask is through research, so it's free, but they would have to sign a consent, an electronic
Okay.
consent.
And then I'm gonna put the asktheexpert.org on the show notes for people to link it back if they want to go there. Is it just asktheexperts.org? Is that the website?
It is, yes.
Okay. All right. So we'll put that on the show notes. And then the self-pay card is Enable.
Yes, Enable. And That is one though that has to be the kit has to be in a clinic, like patients can't order it on their own.
Okay. But that would be very simple to put into the process of a clinic because the kid's getting their hemoglobin, their lead level, they're already getting stuck. And then you put it in the card, you send it, and you get the results.
Mhm.
Uh,
Or the Ask capillary kits that
yeah.
are research, that would be the same. You could just do with the finger poke, fill up the tube and send it.
I'll Google that and put the links for that for people who want to implement this. George, do you have any questions? This is a fascinating topic and a fascinating guest today.
Very interesting. It's probably the future of general peds. We always have to have something to do. I guess 2, 6, and 9 is a time to do something. But if you're going to do it to the other visits to 4, you're already doing a million pokes and jabs, and it's a very noisy visit. But 2, 6, and 9 is not so noisy. You might get them in. Then the problem is if you have a false positive, then the drama associated with a false positive, because I had seen that personally when they came out with the sickle screen and the newborn screen, not the sickle screen, cystic fibrosis screen.
Yeah.
Like every other kid was coming back positive for cystic fibrosis mutations, and parents were getting all nervous. Oh my God, oh my God. By the time they got to see the specialist, it took time. 15 phone calls to the pediatrician until they see the specialist. I tell them, I don't worry about it.
Yeah.
Mhm.
Just a test. So,
Yeah.
but with all tests, it takes times to get it adjusted.
It's always hard with tests because you either make it so that you catch everyone and you're going to get some false positives, or you're going to miss people and not get as many false positives. So I think you're just going to have some false positives, especially with commercial labs. But again, we have ways of supporting and confirming it as specialists that hopefully can put patients' minds at ease.
Yeah. I find that a fascinating program. I love the idea of that program. Thank you so much for your time today.
Yep.
I
Thank you
hope
very
you're
much.
enjoying wonderful weather out there in Denver.
It's beautiful, actually. Yeah.
Yeah. Yeah. Denver's got seems to always have good weather for the morning and then it snows in the afternoon.
Yeah. I was going to say, I don't know about always, but I'll take today. It's a nice day today.
Thank you so much for your time. We really enjoyed meeting you. Hopefully, we'll have an opportunity to have you back on the podcast to talk about insulin resistance, which is always complicates my life as to what I need to do and how to diagnose it.
Yep.
Sure. I'd love to. And yes, I hope we stay in touch.
All right.